All right, in Chapter 19, we're going to talk about assessment of high-risk pregnancies. The assessments are going to focus primarily on tests for fetal well-being. We will also take a little bit of a look at maternal assessments and the role that maternal assessment plays in looking at high-risk pregnancies as well. It's important that we, take a moment and look at the risk factors for a pregnancy because, as your book says, identification of risk with appropriate timely interventions can prevent morbidity and mortality of your mom and your infant. We're getting very good with technologies and assessment, screenings, diagnoses to be able to ascertain if there are abnormalities or conditions that are detrimental very early in a pregnancy. And while it still may end in a pregnancy loss of that one specific fetus and prevents it developing into a child, you may be able to save a mother's life and have subsequent children down the road. So when you're looking at your risk factors, you can actually break them down into certain categories. And the first one we'll talk about are the biophysical risks. When you're thinking genetics, consider your hereditary disorders, things like your sickle cell or your cystic fibrosis, or chromosomal anomalies. Is there anything in other family members, maybe a cleft lip or a cleft palate, that could put this fetus at risk for congenital abnormalities? In looking at your mom, what is her medical or obstetrical history or related illnesses? Does she have chronic hypertension? Is she gestational hypertension? Is she preeclamptic? Does she have a pre-existing cardiac issue? Is the pregnancy she's carrying a multiple gestation, twins or triplets? What's her ABO-RH? Is she RH negative, which could lead to RH incompatibility with a fetus? All of these things, the associated illnesses, have the potential to impact fetal growth, thereby posing a risk for intrauterine growth restriction. Another thing to think about is the mom's nutritional status. What is her weight going into the pregnancy? Is the weight gain or weight loss appropriate to what her pre-pregnancy weight was? What's the birth interval between her pregnancies? It's recommended a minimum of 12 months between pregnancies, longer if you can. So if she had a baby in April and then in August or September she's pregnant again, her body probably hasn't recovered. And something as simple as, is she taking her prenatal vitamins? Smoking has shown a strong correlation to the risk for growth restriction and low birth weights in our babies. And something that seems relatively simple, like consuming more than 200 milligrams of caffeine, has actually been studied and seen associations with growth restriction and miscarriage. There's the obvious risk with your adverse lifestyle that is associated with the use of drugs or alcohol in pregnancy, because that puts the fetus at risk developmentally. And at delivery, the neonate is at risk for fetal alcohol syndrome, neonatal abstinence syndrome, issues specific to the baby that we'll discuss in later chapters. In looking at socio-demographic factors, you ask yourself, is the mom keeping her prenatal visits? We say she receives adequate prenatal care, but adequate prenatal care isn't a reflection of, is the doctor managing her pregnancy? Adequate prenatal care is established by her attending the appropriate number of visits to be able to receive the pregnancy care she needs. So, the question you ask is, can she even access prenatal care? Is there a provider in her area? Does she have transportation? Can she afford prenatal care? Is she uninsured? What kind of support system does she have? Does she have the emotional, psychological, financial support that she needs? And what about age? Think about your adolescents. your 16 or 17-year-old pregnant female, she's still just a kid herself, and she may very well be dependent upon her mother to manage her, and she's not managed to care for herself or a pregnancy and a fetus. On the other hand, your woman who is over 35 is considered advanced maternal age, and she has potential for genetic anomalies, chromosomal abnormalities, and the possibility of an increased birth interval. We talked earlier about a short birth interval being an issue, but imagine your advanced maternal age woman. Her last child may have been 5, 6, or even 7 years ago. You think her body is going to behave and act the same way now as it did, 6, 7, 8 years ago? Probably not. While ethnicity in and of itself is not a risk factor, race can indicate other risks. An example, your African Americans are at a higher risk for preterm labor and preterm births and low birth weight babies. It's also going to be important to do an assessment on the environment of the mother. You have to, determine, does she work around pollutants or hazardous chemicals? You think about your nurse working in the hospital and she works in the oncology unit. Do you think it's going to be safe to let her continue working in oncology around chemotherapy agents if she's pregnant? And we don't need to limit this to just the mother. There has been research that has shown paternal exposure to chemicals or other hazards has the potential for a pregnancy to miscarry. And you have to think about, the father donates half the genetic material. Miscarriages in the first trimester a lot of times are associated with genetic anomalies. So you can appreciate the paternal influence, and their environmental hazards need to be inspected as well. So how do we look at the pregnancy and the fetus to determine if there are problems? Well, antenatal testing will give us information regarding fetal well-being, which is a direct indication of fetal oxygenation and status in utero. If there's a concern that oxygenation could be disrupted, such as through placental insufficiency, poor growth, congenital abnormalities, well, the mother can have a non-stress test, a contraction stress test, or a biophysical profile to assess fetal well-being. These tests are done either in the office or in the hospital, and each test will tell us specific information, with the BPP giving us the most specific and complete assessment of the fetus, even to the point of it being considered a physical exam of the fetus. And we're going to talk about each test in a little bit more detail later in the lecture. So we're going to start with the easier and go to the more complex. Your daily fetal movement counts are pretty commonly referred to as kick counts. Kick counts are a safe, non-invasive assessment of fetal well-being that can be done at home by the mother. Typically, the mother gets instruction to, 2 or 3 times a day, go and lay down on her side in a nice, quiet, stimulant-free area, like her bedroom or something, and just lay there counting the times that she feels the baby move. You want to feel at least 3 kicks in an hour. Now, there's no set evidence-based exact number of movements that are required to say the fetus is doing well, but a general consensus is you should get at least 3 kicks per hour. If you get less than 3 kicks per hour, the baby may be in a sleep cycle. Remember, babies will sleep in utero 20 minutes or so. So you can give it a little bit longer time. You might, not evidence-based practice, but have the mom eat something or drink something to see if maybe there's a stimulation to the fetus that way. If there is no fetal movement detected by the mother for 12 hours, that is considered an alarm. Okay, that's something you want to pay attention to. Mark it down. At some point, you will see the skin No fetal movement in 12 hours is a fetal alarm signal. So moving on into ultrasound. The ultrasound will let us look at the fetus, and in varying degrees depending on which type of ultrasound you do. Standard ultrasound is used most common, okay? It's what everybody's familiar with. It allows for a basic overview of the fetus. You can look at anatomy, you can look at cardiac activity, you can look at fetal movement, fetal growth, you can check amniotic fluid. If the ultrasound is being performed early in the pregnancy, then the sonographer may use a transvaginal approach as compared to an abdominal ultrasound. The reason you would have to do that is the uterus and the fetus is not high enough up to visualize through the abdomen. If your fetus or your pregnancy is 6, 7, 8 weeks along, you're never going to get it going abdominal. So you'll use a wand, you'll insert it vaginally. A benefit to a transvaginal ultrasound is that there's no need for the woman to have a full bladder. That's a requirement for an abdominal ultrasound. And when you're pregnant and you have a lot of bladder pressure anyway, that can be a benefit for you. A transvaginal ultrasound can also detect an extra uterine pregnancy or an ectopic pregnancy earlier, which will allow for a more timely intervention, meaning you could theoretically prevent an ectopic rupture. You'll be able to save the tube and you can preserve fertility. Sometimes a simple scan will be done to determine position, such as in the case of a breech presentation. So, if you admit somebody and you do a pelvic exam and you're not sure if you're feeling the bottom or the top, they can do a bedside ultrasound and just kind of see the orientation of the fetus. If there are concerns regarding fetal abnormalities that need a more detailed exam, then a specialized or a targeted ultrasound will be performed. These are typically done in maternal fetal medicine practices. That's not going to be just your standard ultrasound in any standard hospital. You would expect to see this type of ultrasound, a targeted scan, if the amniotic fluid volume is abnormal, if the alpha fetoprotein result is abnormal, or even if you have familial anomalies such as neural tube defects, cleft lips, cleft palate, congenital heart issues, anything that's going to take a more detailed and in-depth ultrasound assessment. 3D or 4D ultrasounds are really more for entertainment than anything diagnostic. With this type of ultrasound, it allows the parents to, quote-unquote, see what their baby would look like. You can look at the pictures here. You can actually see contour to the face. You can see very detailed nose, eyes, lips. It can help the mother, identify the fetus as a separate entity. So that will help her with accepting the pregnancy. It can also be utilized to help make the decision to continue a pregnancy as opposed to terminating a pregnancy. Remember, it is the presence or the absence of cardiac activity on ultrasound that is definitive in diagnosing viability or demise. On ultrasound, cardiac activity is present at 6 to 7 weeks gestation. That is indicative of fetal well-being at that gestational age. The fetus isn't going to be doing, it's actually an embryo, not going to be doing a whole lot more. So on ultrasound, cardiac activity, 6 to 7 weeks, is indicative of fetal well-being. Fetal measurements are collected with ultrasound, and that can help determine gestational age. It's based on things like your crown rump length or biparietal diameters or your femur length. If a woman is uncertain of the first day of her last menstrual period, you can use an ultrasound to do a dating scan. And if they're done in the first trimester, they're pretty accurate. Now, as the pregnancy advances, ultrasound dating becomes less reliable. If you are trying to confirm a due date and you're using your last menstrual period to determine, you want to say, okay, is this right or not? Well, you can get an ultrasound and look at any correlation. If the due date that is set by the ultrasound falls within 7 days of the due date determined by her last menstrual period, you will always go with the last menstrual period for a due date. So if her period calculates out to a due date of December the 14th, an ultrasound calculates to a due date of December 10th, you're always going to go with the period. So her due date would be December the 14th, even though it's a few days later. Okay? Now, whatever due date you pick at the beginning of the pregnancy is the due date that you use for the entire pregnancy. Even if you do more ultrasounds, every time you do an ultrasound, chances are you're going to get a different due date. So you can't keep changing them. Whatever you choose to begin with is going to be the due date for the entire pregnancy. You can also use ultrasound to evaluate fetal growth. You'll take serial ultrasound and you'll just, compare changes in biparietal diameters, limb length, abdominal circumferences. Those changes will be growth measurements. Now, as previously mentioned, ultrasound assessments are used for anatomy evaluation and identification of abnormalities in the fetal structure. It's also to look at the cord in the placenta to see if you've got a 2-vessel cord as opposed to a normal 3-vessel cord, or could there be calcifications going on in the placenta, or maybe the placenta is not in a good place. It could be lying very close to the cervix, so it would be a low-lying placenta, or it could be covering the cervix and you would have a placenta previa. Another benefit of having ultrasound is that you can use ultrasound to help other tests. Think about your amniocentesis. If you have an ultrasound, you can visualize where the placenta is, visualize, the uterus, any fluid pockets. You will have more success at drawing off the amniotic fluid and less possibility of accidental piercing somewhere you're not supposed to, going into the placenta, and then having subsequent bleeding or even more than that, hemorrhage. Assessing amniotic fluid volume is important because low fluid or oligohydramnios or excess fluid, also known as polyhydramnios, is usually associated with abnormalities or stressors of the fetus. If the amniotic fluid volume is less than 5, you have oligohydramnios. A level of 5 to 10 is low normal, 11 to 20 is normal, 21 to 25 is high normal, and amniotic fluid volume is greater than 25 is polyhydramnios. Now, oligo is associated with fetal renal abnormalities, also growth restriction and fetal distress. Your polyhydramnios is associated with neural tube defects, multiple gestation pregnancies, maternal diabetes, and fetal hydrops. Now, hydrops is a pretty serious fetal condition where you have an abnormal accumulation of fluid in 2 or more fetal compartments. So you will have ascites or pleural effusion or pericardial effusion or skin edema. Okay, so 2 or more of those. Doppler analysis of fetal blood flow through uterine and umbilical arteries can give insight to potential perfusion insufficiencies, which could influence fetal growth and well-being. The ultrasound is also used to evaluate 4 of the 5 components of the biophysical profile. Now, I'll go into a little bit more detail about BPPs later on. As a nurse, you have a pretty significant responsibility in talking with the patient and educating them on what each test looks at and how it's going to be performed. While you don't interpret results, you need to be familiar with what the results do indicate. Now, while I haven't seen MRI utilized in prenatal care, especially according to your text, it is a valid form of assessment and it's safe for your mom and your baby. Similar to a CT, the MRI does give pretty good imagery of the soft tissues in your fetus, but the MRI does not use ionizing radiation, so we don't have to use contrast media. It can take up to an hour or so to complete an MRI, and in that hour's time, it's a pretty good likelihood that the fetus is going to be moving, and the fetal movement will obscure fetal detail. The sad reality is the only way that you're going to prevent fetal movement is to sedate the fetus, which is not something we want to do. Fetal sedation is a practice that's only implemented when full and clear fetal evaluation and imagery is critical in determining our fetal well-being. Alright, so an amniocentesis. This is an invasive procedure that uses a syringe and a needle. It'll pierce through the mother's abdomen, enter into the uterus, and will aspirate amniotic fluid. The amniotic fluid contains fetal cells. Once it's collected, we can do various testing on the cells. We can look for genetic disorders. We can determine fetal lung maturity. We can look at fetal hemolytic disease. To do an amnio, the pregnancy needs to be at least 14 weeks in gestation. At this point, the uterus has enlarged enough that it, has risen up, protrudes out of the pelvis and into the abdomen. While we can get really good information from an amniocentesis, it's not without its risk, so you do have to look at risk benefits. Hemorrhage is a significant risk with this test for both mom and baby. Now, we talked about it. We do have the use of ultrasound to guide the needle insertion and penetration into the uterus to help minimize bleeding or injury. If you have an Rh negative mother having this procedure, it's standard practice to go ahead and administer RhoGAM or some immunoglobulin after the test because we don't want to have isoimmunization. Other risks associated with amniocentesis are infection. You could trigger labor. You could trigger a placental abruption. If the needle sticks outside of the uterus, it could hit the bladder or the bowel and cause structural damage there. Or you could even release amniotic fluid into the maternal circulation, which would create an amniotic fluid embolism, which can be fatal. We will discuss amniotic fluid embolisms in later chapters as well. Even with tools to help us minimize bad outcomes by being able to visualize and guide an amniocentesis, bad things can still happen, and the risk to the fetus is pretty much the same as for the mother. You're going to have infection, bleeding, or injury. While less common in today's practice arena, fetal demise is a worst case adverse outcome associated with amniocentesis. The amnio is done to diagnose genetic disorders through identification of marker genes or chromosomal abnormalities. We've already talked about that. But in addition to looking at the chromosomal makeup, karyotyping of the fetal cells can reveal gender if there is a concern about a sex-linked disorder. AFP or alpha fetoprotein levels, if they are elevated in the amniotic fluid, that will help diagnose neural tube defects. You can take the amniotic fluid and use it to test fetal lung maturity. You will take a sample of the fluid, you will mix it with ethanol, you will shake it up, and then you will assess the amount of bubbles that form with the sample. You're looking at the surfactant levels when you do this. You will take one and then you will just, and changing degrees with your mix of amniotic fluid and ethanol will have different levels of the surfactant. The fetal lung maturity assay has shown results that is similar in accuracy to looking at the LS ratio in determining lung maturity. Also, if there is concern of isoimmunization, an amnio is used to identify and follow up after treatment for hemolytic anemia in the fetus. Typically, the amniocentesis for that is going to be performed once the maternal antibody titer is 1 to 8 and rising. And I'll talk a little bit more about that in a subsequent slide. Chorionic villus sampling, or CVS. There's a major benefit associated with it in that it can be performed in the first trimester, usually between 10 and 12 weeks of gestation. So this is, significantly earlier than an amniocentesis and gives you really quick results. So, while having to stop a pregnancy from progressing is never a good thing, okay? But if you can identify problems in the first trimester, it will be safer on the mother to make these decisions than to wait until the pregnancy progresses until later. The sample is a small amount of tissue collected from the fetal portion of the placenta, and because the chorionic villi originate in the zygote, the tissue is going to be reflective of fetal genetics. Now, the CVS cannot be used for maternal serum marker screens because the sample is tissue and it's not amniotic fluid. And we're going to talk about maternal markers coming up. Risks of your CVS are similar to your amnio risk. Your Rh negative mothers are going to get RhoGAM to prevent isoimmunization. And it is really important to stop and think about, it's noteworthy here. We have gotten so good with our screening assessments and the timeliness of the assessments that we're doing that invasive tests like amniocentesis and CVS are really not needing to be done as often as they used to be because the screening and then the targeted ultrasounds together can give us so much more information. A chordocentesis, or percutaneous umbilical blood sampling, is used to treat the fetal hemolytic disease that I was talking to you about earlier, and you do this with a fetal blood transfusion. The chordocentesis will also be used in the prenatal diagnosis of inherited blood disorders. It can be used for karyotyping and detection of fetal infection. The needle is inserted into the umbilical cord, preferably the umbilical vein, and it will use ultrasound to guide the insertion, and you want to go to the point where the umbilical cord inserts into the placenta because that's a stable area and it's not, you're less likely to have extraneous injuries. There should be minimal risk of contamination with maternal blood doing this. However, if there's any suspicion at all, there's a test called a KBT, or a Klein-Hauer-Betke. The KBT is done to confirm that the blood specimen you have is actually fetal cells and not maternal cells. With the chordocentesis, complications are going to include hematoma, hemorrhage, and fetal bradycardia. Alpha-fetoprotein, or AFP, is produced by the fetal liver and is detectable in maternal serum starting as early as 14 weeks through about 34 weeks gestation. The maternal AFP is used as a screening tool to assess the fetus for neural tube defects. If additional markers of unconjugated estriol and HCG are added to the maternal serum AFP, then the screening test becomes a triple marker screen. It will be able to identify Down syndrome risk and trisomy 18 risk, as well as neural tube defect risks. The triple screen is completed by collecting maternal serum samples between 15 to 22 weeks gestation. If you remember from previous lectures, if you're going to screen for neural tube defects, the ideal time to do that is 16 to 18 weeks. But the entire triple marker can be done between 15 and 22. AFP levels are then compared to the defined normal for whichever week gestation the pregnancy happens to be. It's also correlated to maternal age, maternal weight, race, and if she is insulin-dependent diabetic. Now, if your AFP levels and your estriol are low, but your HCG is high, then the identified risk is for Down syndrome. If all three of the markers are low, the associated risk is trisomy 13. Because screening can identify concerns early in pregnancy, it's recommended that all women be offered the test and to be offered it in a timely manner. You need to remember that the maternal serum AFP or the triple screen is just that. It's a screening test. It's not diagnostic. In order for screened risk potentials to be diagnosed as realities, an amniocentesis will be required. The indirect Coombs test looks at maternal antibody screens to determine the risk for Rh incompatibility. We kind of talked a little bit about that in the last unit. If the indirect Coombs, you have the antibody titer, it is greater than 1 to 8 and rising, an amniocentesis will be required because what it will do is evaluate the amount of bilirubin in the amniotic fluid, and it can establish the severity of fetal hemolytic anemia. So, if your baby is lysing all of its blood cells, it's releasing that heme, you're going to have that increase in the bilirubin, and you're going to have an anemia with it. Antepartal assessment is used to determine if the fetal environment is adequate to support fetal well-being. Specifically, is placental perfusion adequate, and does the fetus have adequate reserves to tolerate the stressors of labor? If you have a sick mom, say she's got chronic hypertension or diabetes, or a pregnancy that is advanced past the due date, 41 weeks or more, then we're worried about the placenta being able to support fetal gas exchange. If it can't, the fetus will become hypoxic, and you will see changes in the fetal heart rate pattern that reflect that. The fetal heart rate baseline will be assessed for variability. The ideal level of variability is moderate, with a beat-to-beat amplitude being anywhere between 5 and 10. Minimal variability has an amplitude less than 5, marked as greater than 25. If we see variability in the baseline, we can presume that there is oxygenation of the fetus at the time that the variability is seen. NSTs are performed either inpatient or outpatient, and if doing surveillance because it's an at-risk pregnancy, NSTs can begin anywhere from as early, I've seen them as 32 weeks, traditionally 34 to 36 weeks. While there is no clinical contraindication to doing NSTs, if you do one before 26 to 28 weeks, the results may not accurately reflect fetal status because neurodevelopment is not complete. NSTs are non-invasive, and they're pretty simple to perform. The mother is placed in a semi-recumbent position with a slight hip tilt just to optimize placental perfusion. The ultrasound transducer and the toco are placed on the abdomen, and the fetal monitoring begins. The test runs a minimum of 20 minutes. 20 to 30 is pretty typical. The mother is given a little device that's got a press button on the top of it, and every time she feels the baby move, she'll press the button, and that marks it on the strip so that we can keep up with where the fetal movements are. What we're looking for is an acceleration in the fetal heart rate that correlates to the fetal movement. A reactive or reassuring NST will have at least 2 age-appropriate accelerations in the 20-minute time frame. If less than 2 accels are seen, the test can continue an additional 20 minutes. Same way with kit counts, mom may be encouraged to eat or drink something with the thought that the fetus will respond to the maternal glucose. Again, this is not an evidence-based practice. If the strip is flat, meaning there's no accels, we can use something called a vibroacoustic stimulator, which can be held up against the abdomen and the button pressed for like a second, and it gives a buzz. It's a kind of thing, and the theory is it startles the fetus and it will elicit movements, and with the movement you should see an acceleration in the fetal heart rate. If the NST is non-reactive after 40 minutes, it is generally going to be followed with a biophysical profile or a contraction stress test. NSTs for fetal well-being are generally done 1 to 2 times a week until delivery. Now, if you go to your book and you look on page 575, down at the bottom, box 19.6 will give you indications for both your non-stress test and your contraction stress test. So here in this strip, you see an example of a reactive NST. Note, I have circled the accels in the strip for you, and if you look down below that at the bottom where the strip where uterine activity is usually seen, you will be able to see the spikes that the mother made denoting fetal movement, and that the spikes correlate to the fetal activity and the accelerations in the fetal heart rate baseline. Now here you see fetal activity in the bottom demonstrated by the spikes showing up in the strip. However, if you look at the baby's pattern, you don't see a corresponding acceleration in the fetal heart rate. So this would be considered a non-reactive NST. And here you see musical notes. Now I've circled them so they're easy for you to identify. The musical notes indicate use of the vibroacoustic stimulator. If you look at the fetal heart rate pattern, you will see the acceleration that occurs right when that vibroacoustic stim happens. Baby's heart rate goes up, stays up for a little while. That's a positive result from using the vibroacoustic stim. Alright, a contraction stress test, or CST, can sometimes be referred to as an oxytocin challenge test or an OCT. The CST is utilized to determine how the fetus will tolerate periods of hypoxia that it has to endure during contractions of labor. If the fetus is well prepared for labor and has built adequate reserves, it will be able to tolerate the stress of a contraction pretty easily. You're not going to see signs of hypoxia. The thought is that if a fetus can't endure a minimum of 3 contractions without demonstrating hypoxia, it's probably not going to be able to tolerate a full labor. It's important to understand CST provides much more specific information about the fetus than an NST, and it has fewer false positive results. So a CST provides more specific information, and it has less false positive results. Even though it is more specific and informative, it is not used freely, and there are specific contraindications to a CST, whereas there's not contraindications to an NST. Absolute contraindications for a CST would include preterm labor, placenta previa, identified basoprevia, incompetent cervix, multi-gestation pregnancy, and a previous C-section where the incision is classical, meaning it is a vertical up and down incision higher up in the uterus instead of the horizontal transverse in the lower uterine segment. To do a CST, first you get a baseline of the fetus for about 10 to 20 minutes. Once you've established your baseline, you will have the mother perform nipple stimulation. Now she will either lightly rub and massage the nipple for 10 minutes straight to promote the oxytocin release, or she can do a 2-minute stim with 5 minutes off, 2 minutes on, 5 minutes off, whatever works best to release enough endogenous oxytocin that we trigger contractions. Our goal is to get 3 contractions that are lasting 40 to 60 seconds within a 10-minute period. If at any point in time during the CST tachysystole occurs, then you stop immediately. Okay, no more stimulation. Exogenous oxytocin, or your Pitocin, can be utilized to stimulate the uterine activity when nipple stimulation is not effective. The dose that you use for this is pretty small, 0.5 milliunits a minute, and you're going to double that every 20 minutes until you get an effective pattern where you're getting 3 contractions in that 10-minute time frame. If you're going to interpret a CST, what you do is you look for the presence of late decelerations in the fetal pattern. If you have 3 contractions but you do not have late decelerations, then the CST is negative. Ideally, we want to always get a negative CST because this correlates to good fetal outcome. If the CST is negative, you're going to bring mom back and you're going to repeat the test in 1 week. The CST will be positive if late decelerations occur with 50% or more of the contractions, even if you have less than 3 contractions. If you only have 2 contractions and you have 1 late decel, it's positive. If you have 1 contraction and 1 late decel, it's positive. A positive CST usually leads to hospitalization of the mom for observation, or even more than that, the possibility of an immediate delivery. An equivocal or an unsatisfactory CST will usually be repeated in 24 hours. In the top tracing here, you see there are 3 contractions in the uterine activity, but the fetal heart rate does not have any decelerations, so that's a negative CST. Now, if you compare that to the bottom strip, you'll see where I circled 3 late decelerations for you. Now, she had 4 contractions, 3 decels, so the decels were occurring with more than 50% of her contractions. Therefore, this is a positive CST and is indicative of poor fetal status. Your positive CSTs have been associated with fetal demise, intrauterine growth restriction, and meconium-stained amniotic fluid. And I said I'd talk a little bit about BPPs, so the next 2 slides are going to go over that. And these tables I pulled from your book. The BPP test includes a non-stress test, measurement of amniotic fluid volume. It measures fetal breathing movements, fetal tone, and overall fetal movement. A normal BPP score is going to be 8 to 10. Okay? The fetal breathing movements, tone, fetal movement, and fetal heart rate reactivity, all of those together reflect the current central nervous system status of the fetus. Your amniotic fluid volume reflects placental perfusion. Advantages of a BPP is the low false negative rates, and there is excellent sensitivity in assessing fetal well-being with a BPP. An abbreviated BPP may just do a non-stress test and an amniotic fluid volume measurement. You got to think about, if you do an NST, if the fetus is reactive, it means it's having accelerations. If you see accelerations, fetal acid base is presumed normal, so it cannot be hypoxic. And if you have adequate amniotic fluid volume, then you have to presume that the placenta is perfusing and functioning appropriately. So what do the scores mean, and what are you going to do with them? Well, if you, each of the 5 areas, you can get a score of 0 or 2, okay? So if you score a 10, then obviously you got a 2 in all 5 of your categories. So a 10 is normal results, pretty low risk of chronic hypoxia expected. You would repeat the BPPs weekly. Now, if you've got a diabetic patient, you would do the BPPs twice a week, and you would also do a BPP on somebody who is 41 weeks pregnant, so she's a week past her due date. A score of 8 is still considered normal, okay? But obviously something has gotten a 0 somewhere, okay? So 8 is normal, but what you're going to look at is see where did the 0 come. If they scored a 0 due to the amniotic fluid volume being low, you need to go ahead and deliver the baby, because if the amniotic fluid volume is low, you're going to have an increased risk for cord issues, for stress, for meconium. You just need to go ahead and deliver the baby. If your score is 6, then there's 2 things that they got counted off on. So 6 is suspicious for chronic hypoxia. You want to look at the gestational age. If they're 36 weeks and conditions are favorable, if the fetal lungs are mature, you're not worried about respiratory distress, you want to go ahead and deliver, okay? If they're 36 weeks but the fetal lungs aren't mature, if your LS ratio is less than 2, you're going to want to repeat the test in 4 to 6 hours, regardless of the LS ratio. If there is oligohydramnios, you need to go ahead and deliver the baby. If you have a score of 4, you're going to suspect chronic hypoxia here. If 36 weeks, just go ahead and deliver. Regardless of what the LS ratio is, anything else you need to just go ahead and deliver the baby. If the gestation is less than 32 weeks, then you're going to need to repeat the score. If the baby scores a 0 or a 2, then you need to strongly suspect chronic hypoxia. You're going to extend the testing time up to 2 hours, so 120 minutes. If you have a persistent score that is less than or equal to 4, again, chronic hypoxia, regardless of the gestational age, go ahead and deliver the baby. Alright, so we've talked about primarily fetal assessments, looking for, concerns for risk. We did mention some maternal assessments that you do. As a nurse, you're going to provide a lot of support and education to your patient. Anytime you tell a woman that she has to have additional tests, that you want to take another look at her baby, she's going to freak out. I mean, it's just plain and simple, okay? So you need to be sure that you understand what's going on so that you can explain to her what you're doing, okay? You need to make sure she knows you're going to be there observing and supporting her during the screens, during the testing. It is not our place as nurses to interpret what we see in any test. That's the provider's responsibility. It is up to us to be able to understand the test, to understand the result and the outcome, so that we can provide the necessary support to our patients. So that's all we have for Chapter 19. Chapter 20 is going to be our pregnancy at risk, and we're going to be talking about pre-existing conditions.